Hey, hi everyone, and welcome to our webinar today. We're very excited to have you join us today for our topic, which we're calling Medical Review. It's heating up, strategies for staying cool. My name is Ken Bell. I'm the Vice President of Marketing for Simple LTC. We're super excited to have you with us today and also to partner once again with QRM, or Quality Rehab Management, to offer this free educational opportunity for you. So as we all know, summer's right around the corner. In fact, I think it starts on Sunday, and the high in Dallas today, I heard, is going to be 97 degrees. And so just like the weather heating up, medical review is heating up as well. And CMS announced, as you may know, on June 3rd, that MACs may now begin conducting post-payment reviews of line items and services with extended dates of service later than the current March 2020. So today we're going to discuss what we're seeing in current medical review activity, as well as the primary differences between medical review under PDPM versus RUGs, how to be prepared, and specific pitfalls that you should be looking out for. So before we dive in, just a couple of quick housekeeping items. Questions and answers. You can ask a question at any time during the session today. Just click on your Q&A button on your Zoom panel and you type it in there. We'll monitor those questions as they come in. Amy's going to be taking a look at those, and then we'll cover as many of those toward the end of the session as we can. And also just note that you can upvote questions from other attendees if you see one that you specifically would like to have answered as well. And then also, handouts are currently available. We had trouble with our original link. Jessica's working on that right now, but check the chat box and she'll have a working link there shortly. If you don't already have the handouts, you'll be able to click on that link and download that in PDF format. Now I'd like to go ahead and introduce our speaker today. Susan Krall is the Chief Strategy Officer with QRM, or Quality Rehab Management. She's a physical therapist with over 30 years of multi-state post-acute rehab management experience, and her client base includes for-profit and nonprofit SNFs and CCRC campuses all across the US. Her primary focus with QRM is partnering with clients to identify and implement strategies that drive enhanced outcomes and patient satisfaction in our rapidly changing PDPM world. So again, we're super excited to partner with QRM today. So Susan, I'm going to turn it over to you to get us started.
Thank you so much, Ken. We really appreciate this partnership with Simple LTC. Sorry that I'm here to bring such a Debbie Downer topic today, but better to be prepared than not. And CMS has definitely given us the alert that things will be heating up a little bit. So as Ken mentioned, we want to make sure that we leave you today with some strategies that you feel like you're better prepared for success underneath the scrutiny that we know is upon us now. So our objectives are to talk a little bit, as Ken mentioned again, about what's the differences between what we were scrutinized for under RUGs versus what they're looking at us for under PDPM in the medical review space. What we've seen to date, how are we going to mitigate our risk? And then what are all of the different auditing entities that are looking at us? How do we monitor for activities so that we can respond timely to the appropriate party? And then share some keys to success. So I hope that you can take something away from this. If you need more on this topic, obviously we want you to let us know that in the chat or in the questions at the end. But we learn more every single day. So moving forward on this, I think we're ready to jump in if everybody's ready. Looking at what would be scrutinized under the RUG system? As everybody knows, under RUGs, categories trumped each other when we were paid under RUGs on our skilled stays. And so you ended up with either a therapy category or a nursing category. And therapy trumped nursing unless the patient was on the highest of extreme clinical cases with isolation and really, really heavy extensive care. So really what we ended up looking at for over, I think 97% of the claims were, did the days and minutes of therapy support the RUG category that was billed? What were the ADL in splits, which was all about section G on the MDS, but really the days and minutes of therapy drove, that big reimbursement chunk. So it was retroactive and it was looking at, what is it that was delivered, and did the RUG category that was billed match the therapy minutes that were delivered? And was the therapy that was delivered in the stay skilled? basically, were you delivering 5 days of therapy on a consistent look back window? It's very department specific, right? So you fast forward to PDPM, where there's 161 items on the MDS driving reimbursement. Nobody trumps anybody else. You guys all know there's the PT, OT, nursing, or speech, NTA, and nursing categories that all have a reimbursement tied to what drove the capture in that category. So what are those big drivers that impact each of the components that they're going to be looking at? We know the big drivers they already are looking at are, did we claim the correct active diagnosis? Diagnosis, as you guys know, will impact your PTOD category capture, can impact your speech category, and it can impact and does impact your NTA, which is tripled in the first 3 days of the stay, which is something they're going to be looking very closely at. And again, we've got the GG functional scores, which impact our nursing and therapy in a big way, right? So GG functional scores already on the radar and a lot of activities surrounding that. We'll talk more about that in a minute. Also, very big and important drivers. And again, all of these items are important for our clinical delivery of care. If someone is cognitively impaired, we need to know that, right? We need to know it so we can address it and we can deliver the right level of care. So the BIMs, which is an interview set of the MDS, is critical to not only clinical care, but a huge reimbursement driver in the speech category. We also have depression, which is another interview in the MDS item set, PHQ-9 interview, which is part of the nursing driver, huge dollar amount. But why is that? You know, if someone is depressed and we don't address it, they're not going to participate. They're not going to be engaged. They're not going to be, they're not going to make progress. So it's really important from a clinical perspective that we get this right. CMS has just put out, recently put out new webinars that are training videos that are very helpful for the cognition interview for the BIMs and the PHQ-9 interview. So we point to CMS's, their video training. They do great jobs and they do great question and answers, and it's new and fresh. So we highly encourage anyone completing those interviews to go through those CMS training videos. In addition, what are some other big impactors to the bottom line that they're going to be scrutinizing is that swallowing disorder. It's section K, and there's like 4 questions. It's a screening. They're screening questions. Could you possibly have some problems that could develop into a swallowing disorder that could lead to aspiration pneumonia, hospitalization? Why are they putting so much money behind these things? Because clinically, it's critical that we identify these problems proactively and address them. Swallowing disorder will get a lot of attention because it's a significant driver as well of reimbursement. And then again, those clinical conditions and comorbidities that are active, that have the correct physician backup in the documentation to support the diagnosis, are critical to that NTA, right? The NTA component and the speech comorbidities, very important that we capture that, as well as the primary diagnosis for sure. So proactively, we have got to make sure in that first 7-day assessment window that all of our documentation is in check, because that is the one assessment that will set your reimbursement for the entire stay. The one initial one, unless you do the optional interim payment assessment. But that initial Medicare assessment, that first 7 days, we have to make sure the documentation is there for everything that lands on that MDS, right? That documentation sets the stage, critical. So I can't stress that enough. And it's very multidisciplinary now, right? And for one person to capture all these 161 items correctly, accurately, and for, nursing to make sure that everything is in there, it requires everyone's clinical skill set, everyone's clinical eyes, everyone's clinical documentation, and communication is key. When we start seeing PDPM clicking again, now that we've got COVID a little bit past us, we're getting back to our basics of how we need to communicate towards PDPM. We are seeing PDPM capture move in a direction that we can see people are communicating now. There's teamwork now. So it's working. So keep your teamwork, your meetings, your communication going throughout the course of those first 7 days to make sure you capture everything correctly in your documentation so it gets in that MDS. Okay, so moving on from what's new to what are we looking at in some trends, right? So we've already talked a little bit about section GG and managed care. You know, they're always the ones that are 100% looking at everything we do. And they would, I'm so sorry, I don't want to put a negative slant on that, but it's a little bit stressful. It's time consuming. It's, you know, it's very, you know, I'll say it's very time consuming. So let's do whatever we can to make sure that we're prepared for that request for information. Section GG, we will share that what they're looking at is that signed and dated support as evidence for the interdisciplinary review of usual performance prior to the benefit of intervention. So what we have is a sample GG usual performance tool. There are several out there, but whatever works for you is critical that we are gathering not just one note from nursing and one note from therapy at the time of the eval and to be able to determine what's usual, right? What we're looking for is truly from the minute they come in to up to midnight of day 3 of this day and stopping the assessment when the patient starts to make improvement, we've got to capture usual. How many times does that person eat and drink and move in the bed and transfer and toilet and dress themselves and feed themselves? I mean, those are things that happen throughout the course of the day. So to capture truly that baseline accurately takes an inordinate amount of coordination and work, which is not easy. And I give you guys all the credit in the world for trying to master this. But whatever you do, make sure that there is a interdisciplinary signed and dated support for GG, evidence of determination of the usual performance in the first 3 days. We cannot stress that enough, and you can't do it after the fact. So I'm not sure if we can pull up that usual performance tool right now, Ken. If you can, that'd be great. If not, I'll just keep on keeping on. There it is. Okay, again, this is just something that we created in hopes that it could help. These are the GG self-care items and the GG mobility items that are included in section GG that need to be addressed. Remember, there is that QRP penalty for not assessing the patient as well. You know, we need to make sure at least 80% of our claims are submitted and coded completely. We don't leave dashes on our baseline assessment or our discharge assessment of section GG items. We need to complete these. And we need to complete them accurately because it is driving a lot of information. It sets the stage for expected outcomes that CMS is looking at. Our discharge assessment determines the progress made under our care, which is public information. It's going to be used for QRP. It is used for QRP, could be used for our VBP coming up. So it's critical that we show the progress we're making, accuracy in what that patient admits to us with. What is our goal? Where did they come in at? Day 1, day 2, day 3. What is our discharge goal? When was the decision date? Where are our initials? Where's the rehab initials? And then we also have a location in the tool that has a place for everyone to sign. So, and a place for us to determine usual performance. If we can scroll down a little bit, we might be able to see a little bit more in regards to what have we determined as usual and making sure that everyone signs it. And we'll make sure that the one that everybody gets has that place for the signatures of the interdisciplinary team on it as well. So we can go back to the presentation. If you guys have questions on that later, let us know, but we can go back to the presentation and keep on going here. So, let's go back to the BIMs and the PHQ-9 on the prior slide. So when we're talking about BIMs and the PHQ-9, we want to make sure that it is administered according to the REI manual and the CMS video, as I mentioned earlier. But what we see sometimes to watch out for is that as we perform, you can perform more than one interview, different times of the day, changes in condition during that 7-day window. You want to make sure you're capturing accurately the cognitive impairment and the depression. And if more than one is done, we want to make sure that it's clear in the medical record. If you were under review of your score on either of those interviews, you want to make sure that the documentation is in the medical record is not conflicting, it's not unclear, that it's going to be an easy tick and tie between what you claimed on the MDS and what was on your HIPS code on your claim. It needs to go back to what that BIMs and PHQ-9 in the medical record stands up to. So just a head up on that, we see some discrepancies in the medical record. Also, there's a lot of malnutrition, risk for malnutrition, there's kind of confusion in the field. We want to make sure that it's clear in the medical record, and we want to make sure that the physician authentication is in there and present. We also want to make certain that everything is in adherence to the RAI manual. And the isolation has been a big question mark, right? Because there's been a lot of patients right now with COVID that were in isolation or they were sequestered, right? They might not have had an active infection confirmed. They might not have been, they could have maybe just needed to be put in the COVID unit, but not in true isolation according to the RAI manual instructions. So we need to make sure that if we claim isolation, that it is truly in accordance with the RAI manual, active infection present requiring isolation, and that excludes UTI and wound infections and encapsulated pneumonia. We want to make sure that we're very clear on that. So we want to make sure that they're not moving about around the campus or around the community, and we want to make sure that all the services are provided in the room. So we need to be very careful in the documentation. Sadly, we know sometimes that we have team members that are rushed. We have team members that will have a tendency to look at prior documentation and keep copying documentation and accidentally kind of grab a service that previously they went to the dining room for meals. They went to activities. We got to be very diligent if we're claiming isolation. All services were in the room, right? So we can move on now to the next slide. Thank you so much. So now what are we going to do to mitigate our risk? What are some examples that we talked about and we're going to repeat for exposure, right? So that skilled criteria is first and foremost, right? If you're skilling a patient, you better be able to back it up in the medical record. Waiver guidelines were coming at us fast and furious. They're dropping off now, and we're constantly getting that question. Do we still have the 3-day hospitalization waiver? Yes, we do. But we need to make certain that when we're using it, we can back up why we used it, right? We need to make sure we're really clear on that. The more that we can clearly explain why we went ahead and waived that, we want to make sure that it's in the medical record clearly, because 2 years from now, it's not going to be so clear what we were doing probably. Nursing areas requiring additional skilled services. If you're in the bottom 2 nursing PDPM categories, we all know that that is really not reflecting the nursing skill that's being delivered. So then if that's the case, we need to make certain that there's another skilling factor. Could be therapy. If therapy doesn't know they're the skilling factor, they might miss a day. Maybe the patient wasn't feeling so good, so they didn't force that 5 days. There's got to be 5 days of skilled intervention if it's therapy, 7 at every day of the week if it's nursing. Make certain your skilling criteria doesn't get forgotten in the midst of the focus on capturing all the other components in PDPM, right? You still have to have the skilled criteria met, days and, days of therapy or days of skilled nursing, right? The other thing that we've already talked about is GG usual performance. We cannot stress this enough. We continue to see this. We're auditing thousands and thousands of medical records for PDPM, and we continue to see this gap in a timely IDT signed and dated assessment of a decision on usual performance. We see data collection we're doing a better job in data collection, but what we're being scrutinized and looked at is whether or not in place is a timely IDT signed and dated document for GG usual performance. So please double check and make sure your buildings have a system for that. And then of course, our cognition and depression, which we talked about. So include documentation of interviews as substantiation of what is claimed and make sure it's not conflicting within the medical record, right? And then once you identify a problem, we need to make certain that there is if there's something found, we need to address it, right? So if there is depression found, what are we doing about it? We need to care plan it. We need to do everything we know we need to do to address cognitive impairment and depression if identified. Okay, so we can move on. And now we can talk about more PDPM specific exposure. So active diagnosis, let's drill into that a little bit more. What do we mean by active diagnosis, right? Are we seeing signs and symptoms of a problem? Is there medication? Is there to address it? Is there physician authentication with the diagnosis within the past 60 days? Is that found in your medical record? Is the physician documentation upon admission there to ensure the capture of diagnosis within the MDS look back period? Make sure if you're claiming something in the hospital, you've got that in your medical record as well. It needs to be active within your look back window unless it states otherwise in the REI manual. And then you've got your physician's signature on the hospital H&P. Let's make sure the documents are signed that we're using. We don't want to get caught up in that. And then we want to make sure that with malnourishment, as we talked about earlier, there's a nutrition evaluation in the presence of the medical record that can be found to support while that malnourishment was captured. And again, querying the physician to verify as active diagnosis is so incredibly powerful. Surgical wounds, oftentimes we know they're there, but we just don't see that documentation of active treatment. Oftentimes it happened, but the documentation just didn't quite make it clearly in the medical record for capture. And then with diabetes, what's happening with active management of the diabetes? We need to make sure that that's clear, and the medication addressing the diabetes. We need to make sure that there is, again, the documentation to support what we're seeing in the medical record. I think at this point, we're going to pull up a triple check document that we have also, tweaked a little bit. Obviously prior to billing, you need to make sure that everything in the medical record is there to support what's on the MDS, that it's there, it's captured correctly. And as part of the triple check, we want to make sure all of those MDS items that are captured in your HIPS code are there in the documentation to support that HIPS code capture. We want to make sure all those diagnoses get on your claim and that your HIPS code accurately gets on the claim. We often find, don't ask me how this happens in the electronic world that we're in, but we often find the HIPS code on the claim doesn't match the HIPS code on the MDS. We find the HIPS code, diagnosis on the claim are not the diagnosis in the MDS that were used to drive the HIPS code. Again, I don't know how this happens. All I know is in the triple check, that's the time to catch it. Is the documentation there? Is it in the MDS correctly? Is the HIPS code an accurate reflection of what that patient presented with? Is that correctly represented on the claim? So what we've done with this is a triple check form, pretty standard triple check form, but we've added some of those components in here. It's pretty microscopic. We're going to make it available to you, but this is a thorough triple check form for Medicare Part A, not just specific to just those little PDPM, just the PDPM components, but the entire claim. We want to make sure there's no technical issues that's going to trip the trigger of a medical review. We want to make sure everything is there, current, accurately verified. So we can go back and we'll have that available to you guys, but let's go back to the presentation and continue on a little bit. Okay, so we can move to the next slide, right? So who are all these auditing entities that are looking at us? This is ridiculous, right? We've got auditing entities that can review Medicare Part A or Part B claims. As we know, it's heating up. They're looking at us in more recent timelines, and we are still getting medical review. Looking back, I just was experiencing a situation this week from a new client that acquired a building, and they're looking back to 2018, 2019, a couple of providers prior with different software. Where in the world is the documentation? How are we going to get our hands on it? Always know where the documentation lies and how to get your hands on it. And then all of these little entities are looking for identification of improper payment. And then if they find improper payment, they're going to communicate it to the MAC for reconciliation or recovery, which means they're going to take back money or end up in a situation where your money's upheld, and that we don't want any of that, right? So what we want to do is make sure that we know what's coming at us. So we've got MACs, which are your Medicare Administrative Contractors, your Recovery Audit Contractors, which are RACs, SMRCs, which are your Supplemental Medical Review Contractor, looking for trends, right? Those outliers, that PEPR report identifier, your CERT, which is your Comprehensive Error Rate Testing, and then your UPIC, which is an integrity contractor, unified program integrity contractor looking for fraud and abuse, which we want to stay away from them at all costs, right? The bottom line for all of these is make sure that your documentation is in place, readily accessible, and backs up your MDS, backs up your claim, everything ticks and ties, so you're squeaky clean on the front end. Let's keep going and see what else we've got to look at to see if we can't find some other ways to help you guys. Okay, so, there's a lot of things that haven't changed under the medical review process, like, how many layers are there of the appeals? That it starts with the request for your documentation. Oh, hey, we're just gonna take a look, just here's a claim. We're gonna take a peek, something triggered our attention, or we're gonna do just a random audit. And we're just gonna pick a code and we're gonna ask you to support it. Whatever the case may be, you still have your first opportunity to provide information, right? And then the timeline, you got to get it right. First out of the gate, our best effort needs to be in that very first level of appeal. So what we want to do is make sure that, again, documentation is ready to be pulled in a neat little packet whenever the time comes. You've probably got up to 120 days to respond to that, but every minute counts, right? And then you don't want to miss that deadline. You want to know, and you want to get a head start. And who knows, where in the world, who's going to be monitoring for in your team. Find out who's monitoring first and foremost. Who is looking at the systems that are electronic that you can see in a portal, or you can go into a system, a billing system like FIS, clearinghouses, like Ability, those kinds of things. Make sure that you have a communication line with the contractors that don't have a portal. Request identification of current and outstanding activity. Call or fax them. Who is doing all of this on your team? It is so important that you review. Somebody needs to be reviewing that portal for activity. And the recommendation I hear is, once a week isn't necessarily enough. Definitely not once a month. Every day would be ideal. That could be part of somebody's beginning of their day. And then for managed care contractors, make sure you have access and you're monitoring the Availity platform and you're utilizing it. So we've put the link in there for Availity. So make sure you know where to monitor. Make sure you have someone on your team that has access to everything at the fingertips and that they are being held accountable to monitoring it for activity. You don't want to miss notification and miss a deadline and end up in that next level. That is going to cause some serious problems and very serious financial potential impact that we don't want, that we want to avoid, right? First level, know where your resources are, know who your helpline is, and make sure you got that all figured out, okay? Know where to look. So let's go to the next thing. Here we go to alerts. Again, one thing to remember is, and this, we have a lot of activity with acquisitions, mergers, and new providers, and changes in software. On the rehab side right now, as everybody knows, there's a change from Kasamba, which was acquired by NetHealth, which also owns Optima. So from a rehab perspective, we've got software changes from, Matrix, PCC, all the other electronic medical record systems that are being changed as providers and owners change. Know where your documentation is, know what mailing address is on file, right? Make sure that we have a designated person that's going to be responsive to handling the ADRs and they know the process. If you have an address change, if you want to find out what address is on file, we've provided different locations and websites here, right? So report address changes through the internet-based provider enrollment change and ownership system, which is the PAYCO system. And we've got that link right there. Address areas are on the CMS 855A form. And so we've got the electronic version to show you here and the link directly to it. ADRs automatically generate from the other address in the FIS system. So make sure you know what that is. Make sure all required fields are completed with the appropriate signatures so that we just don't have things lost in the mail, right? We've got to make sure that we're on top of things. All right, what's coming up next? All right, how can we make sure that you're covered and that you're going to be successful in this situation if it should arise, right? So We've got to make sure that everyone understands with PDPM what it is that needs to be documented to be captured on the MDS. If it's not in the documentation, it didn't happen, you can't collect it, you can't capture it. So PDPM component education, and what we have found is that we have a lot of new players. We talked about that last time we were together about getting PDPM kind of reinvigorated. Let's do some retooling for success. Let's do some re-education. Then we have new players. We lost, sadly, a lot of our team members during COVID. Let's make sure everyone on our team, nursing especially, is a key driver to the biggest percentage of impact to your reimbursement. We've got to have it from nursing and therapy and your physician. Your physician is key. If his documentation and diagnosis coding isn't what it needs to be, you're leaving money on the table, and your patient's needs are not going to be met because they're not going to be identified. So the physicians need to know what to look for. We've got all kinds of physician cheat sheets out there. And who's going to be responsible for making sure that things like your diagnosis that are claimed are all active? Who's going to own the responsibility of reaching out to the physician when a diagnosis code isn't the correct one to map to a comorbidity or an NTA item? Who is responsible for those items? And in your communication, once a week, having a meeting for PDPM is not going to work, because you're going to miss opportunity. Your assessment reference date is going to be upon you, and you will have missed the opportunity to capture what happened in the hospital, perhaps. What was the right primary reason for them to come into the SNF? Did we pick that right ARD date? Did somebody really get on the GG communication for every shift, for every one of those items that needs to be captured correctly for baseline? Did we have a chance to review your HIPS code capture before the ARD was set and you lost the opportunity to really go back and make sure that things were assessed and documented correctly during the assessment window? Are we communicating effectively about whether or not we need to do an interim payment assessment? Was there a change in condition? And was the assessment thoroughly vetted out to make sure that an IPA is something you want to take? There could be things that resolved that would result in a lower reimbursement and not quite the right presentation of what you are treating in that patient. And then we want to make sure that we're communicating effectively to make sure we're moving the patient through our stay safely towards a transition to the next level of care. Are we meeting the goals that are critical? That is so important to us. And is that patient going to have a successful outcome from their stay with us? That's important. It's critical. It's critical to our reputation. It's critical to what is getting publicly reported. It is absolutely essential that we work together, unified in an interdisciplinary approach, communicating daily about the progress of our patients. We just don't have the time not to, right? And then MDS accuracy. That's a given, but there's a lot of question marks out there. There's a lot of confusion. Have resources available to your MDS coordinator. If you don't have an organization with that, find your organization that can be your support and your lifeline. We find that has been something that has been in huge demand by our client base. So please, we've got to have a network for support for our MDS coordinators. It's too much for one person. The completion all has to be according to the RAI manual. The ICD-10 coding has to be checked for mapping to make sure you get credit for the ICD-10 code. Make sure it's the right code. Make sure your documentation is all there to back up your MDS. Make sure your diagnosis coding is active, substantiated, and clearly backed up by your physician. Make sure your orders are there, signed, and everything is done in accordance to the timelines that we are given. And make sure your triple check is effective. It saddens me that we've had to become so fragmented with COVID. We have lost that very thorough triple check, but it's coming back. We're excited to see teams reunite. We're excited to see people that are asking the questions about the triple check, clear technicality issues during triple check. Make sure the documentation is there. Make sure the MDS is an accurate reflection and capture of that documentation. Cannot say enough how critical that is, that MDS, accurate HIP code, and diagnosis codes make it to that claim on the UB. Triple check is key. Okay, next. We do not want you to put your money at risk. Every penny counts. We are strapped in this industry and we want everyone to survive, and we want everyone to be able to have the resources at their fingertips to take care of our patients, our very vulnerable patients that we care for every day, and the staff that cares for them with the resources that they need to care for our patients. So what can we do to help, right? We want to make sure that everyone understands the critical importance of proactive, not reactive or retroactive documentation. It won't work any longer. There's nothing we can do to go get a BIMs completed after the fact if it wasn't done in the assessment window in the timeline. If there wasn't GG assessment, we can't do it after the fact. We've got to have documentation from the beginning. It's got to support your GG score, your individual PDPM components, and your interviews. What's your best defense? Your best defense is really a complete and well-organized record. None of the reviewers want to get a mishmash of paperwork that they have to thumb through and try to figure out how are you defending this claim, right? So we want to make sure we're well ahead of the timeline. We present a complete and well-organized record. It presents a strong clinical argument with very clear medical necessity and physician support, and that we meet all of the timelines. And then we use every recourse we can to present our discussions and our arguments. And please know your resources. We're here for you. We want to help you. We want to provide tools for you. We want to do everything we can to make sure that your money is not at risk. So what have we got next? This is a little bit about QRM. We want to make sure that we're doing everything correctly. We want to support everyone. We cover everything in our in-house rehab management, from making sure that the right care is delivered at the right cost, the right team members are in place, you're getting paid appropriately, you're supported through your medical review, and most importantly of all, the results are there for our clients. Okay, so Amy, do you have some questions for us?
I do. So the first one is
actually, hey guys, can we hang on just a second? Because I want to do a really quick poll and highlight on Simple Analyzer and Simple LTC. We've had a few questions coming in about QRM as well as about Simple. I just wanted to note that Simple Analyzer is the post-acute analytics platform provided by Simple LTC. And this is a platform used by currently thousands of facilities all over the country for MDS analytics, real-time quality metrics, including PDPM performance, 5-star insights, and you can get some insights into the types of issues that we're talking about here as well today. So I wanted to run a quick poll. So let me bring this up real quick and then we'll jump right into Q&A after that. So if you're interested in learning a little bit more about QRM or about Simple LTC, this is your way to let us know now. So we'll just leave this up for a couple of minutes here. So feel free to say yes or no on either of those. If you're interested in learning about QRM or about Simple LTC, let us know here and we'll follow up with more information. And at this point, why don't we go ahead and go into Q&A.
Thank you, Ken.
Thank you, Ken. All right, first question, Susan. Do you find that therapy documentation needs to include a statement that services were provided in room for patients on isolation? Are you seeing isolation coding denied due to the lack of this in the therapy documentation?
Absolutely, that is key for everyone to document that the services were provided in the room. It's key to supporting that claim of isolation. So it's not just therapy, it's meals, it's, every nursing care delivery, it's everything in the room. So yes, absolutely, great point. Thank you.
Next, has QRM seen any info on when TPEs will resume beyond later than this year, which was indicated in the MLN article?
No, only that 613121 CMS communication that they will resume at a later date. So I hope that helped. We'll keep our eye open for sure. And everybody, let's share what we hear and learn, right? So thank you for that.
Okay, true or false? Appeal redetermination request of a RAC denial is submitted to the RAC.
Actually, that's not true. So appeals on redetermination requests are submitted to the entity that are processing the claim post the RAC decision, which is the MAC. So I hope that's helpful. Okay.
Who is the SMART contract currently being held by?
So that's Noridian. And Meridian has done a little helpful thing. They have decided that they're going to put their communication in green envelopes. So please alert everyone in your buildings to watch out for green envelopes and make sure they know who to give it to, right? So that we're not missing that SMRC, investigation. We don't want to miss any of those. Okay, and that's from Meridian.
Does 3 days of data collection satisfy requirements for MDS section GG?
Again, GG, so important, hardest thing to do, right? Because actually that is not the key. Yes, we have to gather the data for usual performance in those first 3 days by midnight or 11:59 on the third day of this stay. We have to gather all that information, but then we have to document the determination of usual performance. It's not enough to gather the data. A decision has to be made on the usual performance by an interdisciplinary team, signed off on by that interdisciplinary team and dated and put in the medical record. So it's not just the data collection. That will not get you where you need to be on GG. Anything else, Amy?
One final question.
Okay.
Does quarantine as defined by CMS satisfy criteria for claiming of isolation per the RAI manual?
Per the RAI manual, no. Quarantine does not meet the criteria in the RAI manual, and this has caused the biggest area of confusion, and it's frustrating because it doesn't necessarily make sense in what we're having to do with COVID. But we can only code for single room isolation when all of the criteria are met that are in the RAI manual. They have an active infection, it's highly transmissible, our precautions are over and above standard precautions. All of these things are required. The residents in a room alone because of their active infection. They cannot have a roommate. So we had people cohorting that had COVID or suspected COVID, and they had to be kept away from everybody else. That not equals isolation. That does not equal isolation. And again, to the earlier question, all of the services have to be delivered in the resident's room. Everything, rehab, activities, dining, everything. And to the earlier point, please document that in the medical record. Everyone document that in the record. Anything outside of that, you're gonna lose it. We can't afford that. So anybody have anything else for me?
Those are all the questions.
Okay.
If any do come in later, I know Ken said we will share an FAQ document for everyone.
Okay, so the FAQ document will be distributed to everyone. We've shared some resources with you, the links to all of these people that are looking at us, so you can get into more weeds if you're interested on that. I hope that I didn't take up this whole hour. I'm trying to be respectful of everyone's time and let you get back to taking care of patients and doing what you all do best. So we want to really let you know how much we appreciate your time today. And if any of us can help you, we're here to serve. So thank you again, Ken and Simple LTC. We appreciate this.
And thank you so much, Susan, and also Amy, for putting together this content. Very helpful for all of us and all our audience today. We did have several hundred people on the line with us today, and we had a lot of great questions. So thanks to everyone for joining us today. And here's a link to the landing page where we'll have the recording and as well as the slides and the handouts available. And again, Jessica, if you would just post that link one more time. I apologize, we had some problems with that link to the handout slides earlier in the session, but it seems to be working now. So we'll post that one more time. And if you didn't get the slides or the handouts and you want them, just go ahead and download that now from that link. Again, thanks to Susan and Amy from QRM. Thanks to everyone for joining us today. We hope you have a great day.
Thank you.